About CT, it becomes important to understand that look at this picture or in this picture. These are called as the puffed cheek appearance in the patients. So in this puffed cheek appearance, which is a new technique of delineating cancers, particularly in the buccal mucosa, makes the margins of the disease more common for the surgeon to delineate and plan the surgeries. Also important is to understand the spaces around the mandible so that they can plan the multidisciplinary team, particularly if there is a local extension and role of adjuvant or neoadjuvant treatment instead of a direct surgical intervention. MRI particularly has become a workhorse if you are thinking about tongue and if you are thinking about the depth of infiltration and you are planning a primary role maybe of a radiotherapy as an upfront part of the treatment. Orthopantomogram for us as surgeons has been a boon given the point that we have now discussed about the anatomy of the mandible, and the anatomy of the mandible needs to be understood before you think about a mandibulectomy. So, as you can see, erosion of the mandible will usually be considered to be a T4. Will require to have a segment of the mandible that is removed called as a segmental mandibulectomy. Whereas erosion of only a part of this or abutment will only need you to do a sleeve resection called as a sleeve mandibulectomy or a marginal mandibulectomy. Followed by other imagings like a PET CT, which as I have said are only done in a case of a suspected metastasis, is not an upfront investigation. Ultrasound has been a workhorse for a bedside investigation or nowadays in a chair-side investigation, particularly for taking an ultrasound guided FNAC. Sentinel lymph node biopsies have come in a big way and we'd like to spend a minute on that in the perspective that sentinel lymph node biopsies have been the major part, particularly in an N0 neck and in areas, and this is the reason I made up this table for you to understand, is that some sites will have a very low chance when there is a primary tumor, like the floor of the mouth. If it is a T1, the minute it goes to a T3 and T4, remember that the thing changes exactly and then it becomes a potential for a metastatic spread. So particularly if you ask me, these will be the sites where I can consider a sentinel lymph node biopsy. These will be the sites where I will not consider a sentinel, and though we now have a strong controversy, we will like to do a selective or a elective neck dissection in the perspective that there is more than a 30% chance that these primaries are going to go to a lymph node. So sentinel lymph node is done for an N0 neck, particularly if you have thought about that it is a T1, T2 lesion, which has a very less chance of a metastasis, and you need to still evaluate the neck maybe because the grade of the tumor is poor. Now, the final topic to discuss for the day is something called as the role of surgery in head neck cancer. As I have said, surgery for head neck cancer is now a specialty. So you need to understand the principles in this lecture. To begin with, the first one is who exactly does what. To start with, remember that you may be the surgeon and you may be responsible for the surgery. But this needs to plan, and then for a planning, you need to call in a multidisciplinary team. As you can see, there are many members in the team which have their own role. Like you need a reconstructive surgeon sitting by the side of the theater, having a cup of coffee while you take out the tumor. We usually do not do the same reconstruction, given that we need to be more radical. We need the more reconstructive guys to come in after we have taken out the tumor. Parallel to that, when you are taking out the maxilla particularly, you need an obturator and a dental surgeons to be placed, thinking about the planning for a maxilla and a mandible replacement. Radiation oncology and medical oncology will be always an integral part, and particularly in areas when there is a big role of a neoadjuvant chemotherapy, even neoadjuvant radiation now in matted lymph nodes, which are coming in a big way and they need to be discussed. Now, after we have done this, few basic things that have remained true over the time. If you are thinking about surgery for the primary, then your treatment of the neck will also be surgery. Definitely it makes sense. If you are thinking radiotherapy for the primary, because it has been seen that in T1 and T2 at least, both of them have the same results, then the neck, if it is an N0 neck, then you can have radiotherapy. If it is an N1 neck or an N2, N3 particularly, it becomes important to do about a neck dissection. If you are thinking about a recurrence of the tumor, then it becomes an important part to think about which happened first. If it was a radiotherapy, go for surgery. If it was surgery, go for radiotherapy, and particularly we are talking about neck. Local areas with a recurrence is a big challenge, and you again need to discuss amongst them. Principles of surgery. As I have said, we will only be discussing the basic principles. The most important things to understand in any oral cancer surgery is always protect the airway. Always know that, protect the airway. In the airway, that means after you have taken out the tumor, remember that either you can go in for an extubation on the table, and these are usually done for surgeries where you know that lesion has been very small and you are happy that this patient is not going to have a blocked trachea. You can do a delayed extubation. That means these are some things that we usually do, but the problem in delayed extubation is that it eats into your ventilators and produces a technical problem. What is the role of doing a tracheostomy is always to be known, and remember that if you have done an extensive resection, number 2, if you have done a reconstruction as well as an extensive resection, if you have done a bilateral neck dissection, these are the points, and the patient had difficult airway like a Malampatti grade 3, grade 4 previously, it is usually sensible to make a tracheostomy on the table if it had not been done previously. How will you get to the tumor? Well, as we were only talking about oral malignancy, the main point is surgeries on the lip and that part of the tongue and the buccal mucosa are easy. But if you are talking about things that are exactly behind the site, just for example the posterior third of the tongue or the tumors in the part of the tongue that are invading the posterior part, then you need to have for the lower lip something called as a lower lip split or a split mandibulotomy, which means that you cut the mandible by the side of the symphysis and gain access and swing it over the joint. For the upper lip and the maxilla, you have an incision called as a Weber-Ferguson incisions, which will still be allowing you to do a maxillectomy. So these are the basic principles of an access. Definitely when you go for the neck dissections, they will be more important when you talk about. Margins for any surgery is a standard 1 centimeter gross macroscopic margin. Definitely you need to save the vital structures. Regarding mandibles and maxilla, as I have said, in mandible, always remember the lower border of the mandible is very important. So if you are talking about the lower border, as I have said, this is the floor of the mouth, until and unless you have taken out the tumor and the tumor is abutting the cortex and not the medulla, mind you, this becomes a very important thing to remember that we can just shave off this part of the mandible, as you can see, and this is something called as a marginal mandibulectomy. But the minute it involves the medulla, definitely it will not be possible to do that, and with a cancer in place, the extent of the resection, as I have said, if you see the picture of your orthopantomogram or the CT, you will now get an idea that these areas which have now been infiltrated by the cancer by the lucency needs to be taken out, and you may need to even go for a hemimandibulectomy, which produces a big defect and needs a reconstruction.